So now I'm going to change gears and switch to what I call targeted therapies. And in the past 15 years, the field of thoracic oncology has experienced rapid growth in precision oncology. There's been an identification of numerous mutations, which I will call driver oncogenes. So oncogenes are mutations that allow a cancer cell to stay in the growth phase and keep growing. And this is shown in this pie chart from a Sloan Kettering group and from this TCGA data set, which really show the wide variety of different mutations we see in lung cancer. Why do we care about these mutations? Well, this is that same SEER 2021 cancer statistics that I showed earlier. What you see here is if we do a little bit of math, and I would ask all of you to indulge me for a little bit. So we take the number of cases of lung cancer in 2021. There was 235,760 cases of lung cancer diagnosed that year. Let's assume that 26% of these are non-small cell lung cancer. Remember, there was different types of lung cancer. There's small cell and non-small cell. So let's assume 84% of these are non-small cell. And let's also assume that about 45% of these cases will have what's called a driver oncogene. Remember, these are mutations that cause the cancer cells to keep growing and growing and growing. Well, if you do that math, you get 88,424 cases of non-small cell lung cancer with a driver oncogene. These typically are patients who've never smoked. Now, compare that to the number of pancreas cancer cases that year. There was 60,430 cases of pancreas cancer that same year. The point of this is to show that patients who never smoke, who have lung cancer with a driver oncogene, they're very common. And it's common simply because there's so many cases of lung cancer. It's important to know that patients have mutations, but what can we do about those mutations? So these were some really important studies that were done in the early 2000s that looked at this. The first was a very large clinical trial that looked at the effect of giving a drug called erlotinib. This is a specific targeted therapy that blocks a mutation called EGFR. Now, at the time, they didn't know that. And so this drug was given in the third-line setting, meaning patients had progressed on 2 chemotherapies, and they were randomized to getting this EGFR targeted therapy or placebo. Now, in this era, this kind of trial was acceptable because there was no standard of care therapy after second-line chemo. And so placebo was an ethical control. In the modern era, this would not be an acceptable trial design because we have much better treatments. That being said, there was an improvement in the 1-year survival in the patients who got erlotinib and an improvement in the objective response rate. But what's really interesting, and again, remember at the time, they didn't know that there was this mutation called EGFR. They just had this drug called erlotinib. When they repeated this in a separate trial, this was done 4 years later with a different drug. This time it's called gefitinib. This is another EGFR inhibitor. And they looked at the patients who had the mutation, the EGFR mutation, and they gave them the drug that was an EGFR inhibitor. It's no surprise that those patients shown here on the top right did much better than if you did not have the mutation. And so that was the first proof of concept that you can give targeted therapies and that patients do much better. They don't only just do much better, they actually report a higher quality of life with targeted therapies versus chemotherapy. This was shown in this very nice quality of life analysis from the Optimal study.